Yeah. Okay, I think we're on. Okay, good morning, members. Welcome to this meeting of the Health Overview Policy and Scrutiny Committee, today held in Committee Room 1. We're live streaming the meeting on YouTube, and a recording of the meeting will also be available afterwards. We're not expecting a fire drill this morning, so if the alarm does sound, please follow officers out of the building and gather in the cathedral grounds. This morning we have Richard, Jasmine and Michael on our core team, who's in for Charlie, who's on holiday this week. So we'll go to membership apologies, substitutions and declarations. That's you.
That is me, thank you, Chairman. We've had apologies from Councillor Martin Foley, Councillor Paul Gadd and Councillor Stephen Robinson, and also Sharon Westfield Cortez from
I know Sharon's not well, so I hope she gets better. We've extended today's invitation also to Caroline Beasley Murray, who is the lead governor at the Midland South Essex Foundation Trust, in relation to the midwifery paper later on. And I imagine she may arrive at some point during the meeting. We'll go to the minutes of the previous meeting. I've not been made aware of any issues with last month's minutes. So do I have members' permission to sign the minutes off?
Agreed.
Thank you. We'll move on to item 3, which is public, and I've not been made aware of any. Okay. Lovely. So item 4 is our substantive item, the Integrated Care Board's financial position and update. We've got so far 2 of the 4 expected. We've had the 4th one has dropped out and we're waiting on the 3rd, and again we expect him to arrive at some point. He may be held with traffic the other side of the county. So joining us in the chair is Alan Pond, Chief Finance Officer for Herts and West Essex, Chief Executive of the Mid and South Essex ICB. So we've seen your papers, and I'll leave it at that. And I believe, Tom, or Alan, you're going to kick off with a little bit of an explainer before you lead into the substantive papers.
Okay, thank you. So the NHS is quite complicated, both in its makeup of organisation, the financial flows. So whilst by statute we're required to achieve break-even each and every year, we are part of the bigger family of NHS England, and the resources flow into NHS England. They then decide how to allocate funds out. We agree plans with them each year, both financially and operationally, and often we get into the debate about all the things you've asked us to do are not affordable within the funds you've given us. So you either need to change the asks, or you need to provide more funding. And there's the danger that drags on for quite a period of time until you get to a settlement, and often the settlement is not necessarily happy for all sides, because you've had to make compromises, and so we always end up with probably an efficiency and savings target which is very stretching. I think for most organisations in the NHS this year that was about 5%. Now we have to break even each and every year, and we are not allowed to carry forward reserves, which is a difference, as I understand it, from local government, where your funding is a little bit more flexible, albeit you need to demonstrate, if you're drawing down reserves, how you've got a sustainable long-term future. In the NHS, our long-term future is this year. And then by the time we get to this time of the year, we start talking about next year, and trying to juggle then the 2 things about the year you're in and the following year. And in terms of funding flows, we have in the country probably about 200 plus NHS trusts who are the providers of services. So the hospitals, mental health trusts, community services trusts, and all of those are aggregated into what's called an integrated care system. So for Herts and West Essex, that's the population of the 13 district councils. I'll go through them all. And the hospitals and trusts that are assigned to us are, in essence, Prince Alexandra. In Hertfordshire, we've got Eastern North Hertfordshire Trust, Hertfordshire Community Trust, Hertfordshire Partnership, University Trust, and West Herts Hospitals Trust. Now, you'll mention I haven't said the ambulance service. For performance matters, EPA Essex Partnership Trust comes under South Essex. So, as an integrated care board, you have responsibility for the integrated care system and the performance of the partners within the system. So we have a contract with Essex Partnership to provide services to the West Essex population. We're interested in the performance of that service because it impacts on our population. Officially, technically, formally, financial performance of Essex Partnership is not our concern, it's the concern of South Essex. Now, clearly, whenever you're dealing with third parties to provide services, you need to understand their financial sustainability because you don't want them to collapse and disappear, then you've got no service. In terms of the way finances are reported, we would report the financial performance of those trusts within our system, once I've mentioned, and that won't include EPA. And we also report the performance of the Integrated Care Board. We, in effect, receive the money for the population that we then have to spend with various different providers. So that will also include independent sector providers. It will include contributions into the Medicare Fund that is joined then with local authorities. And it will include a whole range of other services, so primary care, GP services, dentists, optometrists, pharmacists, and so on. So we are the convener and the holder of the resources, and we have to plan and decide how to deploy them. When we deploy funds, we have to be mindful of the cost of delivery of services, because if we provide insufficient funding to our trusts, then there'll be a deficit, which we're responsible for sorting out. And if we provide insufficient funds to third-party providers who are not counted within our system, if those funds are insufficient and they can't deliver the services, they'll either go bust because they're overspending, or deliver poor services, lower quality, fewer patients than we would have wanted. So actually, it's quite a connected system, even if you don't have responsibility for all the providers. Because we have to break even each year, there's often a danger that resources suddenly become available, often nationally, and if it's not spent, effectively gets lost. So there can occasionally be what from the outside looks like very short term, not necessarily looking like they're the most highly prioritised things to spend money on, but it's that problem of if you don't spend it, you lose it, and then it comes out too late to really decide what to do. And we often have 1 year allocations, so we don't have that ability to plan into the next 5-10 years. You might say, well, we can make judgments about what our allocation in future years is going to be, but the variability of the growth in funding we receive is pretty volatile. So whilst you can have a medium-term plan that sets the direction, quite often you can't nail down what you're going to do each and every year until you get that year's allocation. So those are some of the challenges we face, but by no means is that supposed to be an excuse for what you're about to hear about our financial position now.
Before start, I just want to check. I think we've got a number 3 on the screen. Do we have Howard? Does Howard join? Howard, can you hear us?
Just promoting him, so he should pop up on screen.
Sorry, I'll just make sure he's in the room. Howard, can you hear us?
Hello. Yes, I can. Yeah.
Lovely.
Can you hear me?
We can hear you, we can't see you. Oh, there you are, we can see you now, thank you. So Howard, you are Chief Finance Officer for Suffolk and North East Essex ICB. In the time you've been joining, Alan's just gone through a little bit about how NHS budgets work, so I'm going to hand over to the three of you now to go through your reports. We have read them. I wouldn't necessarily say we get them, but we've read them, so floor is yours. Thank you all.
Sure. Shall I start from Mid and South Essex and then we can work our way around? That's okay. So for Mid and South Essex, the Mid and South Essex system is made up of Mid and South Essex Integrated Care Board, Essex Partnership Trust, and Mid and South Essex Foundation Trust. So they're three organisations which are amalgamated in terms of the financial position of MSE. And at the beginning of the year, there was an agreement effectively based on the allocation given to the Mid and South Essex system through the planning process, that there would be a planned £96 million deficit. So based on the notional allocation, NHS England said, in effect, we recognise that you're not going to be able to deliver services within that allocation, and therefore effectively here is £96 million more that you can spend on health services this year. And the slight peculiarity and thing I sometimes try to get my head around, the plan we then monitor against is that on that higher number. So effectively, it assumes that we are getting the additional 96 million, and therefore, if we break even on our plan, actually we are 96 million pounds away from what we should be spending on health services in Mid and South Essex. So that was what happened at the beginning of this financial year. Now, there was significant deterioration, as you can see within the paper, against that plan. So particularly in the first half of the year, kind of peaking up at just over 30 million deficit. That was driven by a number of factors, but the key elements of that were principally that was being driven through hospital services and much greater spend on staffing than was originally included within the plan. So that's staffing for wards, that's use of back agency staff, so higher cost staff in order to provide that coverage, and also excess costs in certain specialties where the hospital has historically struggled to recruit. So high cost staff were secured for that purpose. To a lesser extent, we also saw that within Essex Partnership Trust as well, but to a lesser extent. What we have seen in the last 2 months is we have started to see an improvement in that position. So there's been a series of actions that have been taken in terms of making sure that money is spent wisely. So the hospital has introduced a turnaround programme, which is challenging all areas of spend, making sure that there's the correct use of staffing. And we have seen an improvement for the last 2 months in terms of the hospital position. And equally, we've also seen, to a lesser extent, but we have seen a slowing of deterioration in the Essex Partnership Trust. At the moment, the ICB is on plan to deliver its the biggest component of sort of the ICB variable spend being continuing healthcare. But we obviously work closely with council colleagues on. So it's high risk in terms of the delivery of our financial position this year, given the deterioration we saw in the first half of the year, and we're at this moment in time. I think there's some key learning for us as a system as we go into kind of the coming financial year. The big element of that being we've got to pay much greater attention to workforce planning in the Mid and South Essex system, because I think historically one of the issues that we've had is we've seen financial planning through a finance lens, as opposed to finance actually is the end outcome of the way we run the service, the way we staff the service, and the way that and the way that the service works. And so we're taking a different approach to planning this year. So looking at actually what are the drivers of the cost, and therefore what do we therefore need to do to the drivers of the cost in order to deliver the plan, as opposed to try to goal seek a particular financial number. Not saying it's going to be easy or challenging or easy, but that's very much what we're working towards. Alongside this, and something that I think we'll be bringing back to this committee in due course, is we've been doing work around our medium-term plan. And so that more broadly says, what does the future shape of health services in Mid and South Essex need to look like to better meet the needs of our communities, alongside actually being able to deliver within the resources that we have available to pay for NHS services. That's in the process of finalisation at the moment. So I hope in the next few months we'll be have the opportunity to spend some time with you to talk you through that, and how we think that will path to much greater financial sustainability for our local NHS. Within the paper, there's some detail around capital spend I won't go into, but there's questions there, and also just some of the work that's going on around the findings of the Darcy report. That's there.
All right. Before I hand over to Alan, can I reference the Darcy report? Is there a financial impact, the recommendations within that? Does that?
So not in the immediate term, but the Darcy report's being used to inform the 10-year plan for the NHS. And so that's currently going through engagement consultation at this moment in time. And we should see it in the spring, is what we're told. So there may be a financial implication of the 10-year plan once it gets released in terms of specific commitments that are made. The big financial challenge I think we all have going into next financial year is the planning guidance for the NHS and the financial allocations were published last Thursday, and there's some very stretching commitments around reducing waiting times for hospital treatment, which is obviously great, but will cost in terms of us to deliver on those expectations. So that is probably for Mid South Essex system. I'll let Alan and Howard speak separately. That probably is the key issue and challenge we're going to need to go through in terms of how do we deliver.
That report you've got until it's March, isn't it, before you have to make a submission on what your plan is, right?
Yes, yeah. So we're working on that.
I assume we'll have you all back to have a look at what that looks like. Costs. Right. Okay. Alan, Howard.
Okay, I'll go next then. So Herts and West Essex, similar to Mid and South Essex, weren't able to submit a balanced financial plan alongside its operational plan. We had a gap of 20 million as opposed to 96, but it's still a significant number. And again, as part of the settlement, we've given 20 million to break even. The deal for us was that our 20 million was less than our proportionate share of the national pot that they had created. And so as long as we then achieved break even, that 20 million would be in effect a grant, an allocation to us, would not be repayable. So in that context, I'll come on to then say what I need to say. So the target for the year is break even. At month 9, so end of December, the deficit against plans, so the deficit was 23 million against a planned deficit of 16.7. So as you can see, we kind of got back-ended savings. It's not always great, but that's often what happens. You deliver increased savings as you go through the year. Our plan was that 16.7 million deficit would be recovered in the last quarter of the year. And we are at 23 million, so you can see we're 60 million away from that, even that back-ended plan. Our improvement on month 8 was just about 40,000. I think actually we got further updated numbers, which increases it massively to about 100,000. So as you can see, nowhere near enough to get back into balance. However, we have looked at the delivery plans for the last quarter, and if we can over-deliver on what we originally said. We're at the time of writing, we were about 11 million away from getting to break even. So a significant improvement on month 9. Not far enough. Since then, and on Friday, we updated that saying we're about 8 million away. So again, improving the position. Some of this is just really shaking out. We said we were going to spend on various things. Have we been successful in spending that money? So some of it is investment, and often we're over optimistic about the pace at which we can change things and the investment comes to fruition, get the benefit of the investment. So we are finding that there is slippage on some of those investment plans. Now, on the plus side, that means we're not going to spend the money. On the negative side, it means we're not going to get the benefit that was originally intended from the investment until sometime later. So it's a double-edged sword. The forecasts were based on the elective recovery fund that NHS created being audited full. So at the beginning of the year, everybody was encouraged to improve productivity, to increase elective activity, and therefore reduce waiting times and waiting lists. And what's now happened is the success rate of that is probably greater than NHS England expected, and they're finding that they're running out of money. Although we were told you will get you get paid for all the activity you undertake, NHS England are now suggesting that they may have to cap that. And for us, we think we're probably about 15 or 16 million over the cap that they've set. Now, our elective spend that's captured within that fund is just over 500 odd million, so 510 million. So as a percentage, it's relatively small, 2-3%. But because we have to land on the postage stamp of break even, the 16 million shortfall here about in middle of January, it's very, very difficult to recover from. So we're pushing back to NHS England on the basis that we don't think that even if we were to seek to reduce the activity, it probably wouldn't release any cost. So we could be in the situation of saving a fraction of that money, but actually significantly impacting on the numbers of people that are waiting, the numbers that are treating, which just makes the problem next year much more difficult. What we've been told for next year is that the elective recovery fund will be a fixed figure. It's lower than we're spending this year, but they're expecting us to improve the waiting times targets. So that's a significant challenge, and that's why on the face of it, if you ever looked at the assumptions around the allocations that are made, there's a headline 2% efficiency saving. But on top of that, you have to deliver, in our case, about 30 million of activity with less money, 30 million less than we would get with the current. So that's, again, it's quite a big challenge. Every year we get more money, but every year the population increases in number, and the older population increases the fastest. And it's well recognised. You'll probably know it for yourself in the county that the older age range tends to cost more. So cost more both social care, cost more in healthcare. So the challenge is that increase in size of an age of the population, funds that we give, that we receive in real terms probably means cut. Probably less of a cut than you're getting in the local authority, but it still creates a bigger challenge. So we think we need at least 5% productivity and cost reduction between the two to be able to get to a balanced plan for 25-26. The good news is that our deficit has stabilised. So month 1 to 5 was really bad. We had quite a lot of one-off things. So we had in mental health, had to commission services outside of the mental health trust. That's now stopped, but that probably run up a bill of about 3 million. Other factors that drop out. So if you look from month 5 to month 9, our position's been relatively stable. So it's worse by about 2 million. So suggests next year's recurrent position is a bit less challenging than maybe we thought it might be at one time, but it still does require that level of efficiency saving, as I've said. This year, the target was 5%. We're delivering about 96% of that, but some of it is one-off fixes, which will effectively unwind again 25, 26. So we've been looking for another 5%. Nationally, they've talked about efficiency, productivity maybe being 4%. We said it's going to be at least 1% more than that. And so efficiency would take us some way. The national view around structural transformational changes, I think will go a long way to delivering some of that, but I think there will need to be some tough decisions about how we operate, what we can do, what we do with fragile services that are carrying excess costs, how we make them stable and more cost effective. So I think there will need to be changes in the way that our trusts operate with each other and with elsewhere if we're going to deliver the kind of savings that are set out in a recurrent and sustainable way.
Howard. Can you...
Hi. I'm Howard Martin. I'm the Chief Finance Officer for the Integrated Care Board in Suffolk, North East Essex. I'll just start off with some very high level context, really. In this context, when we're talking about system, really, the formal ICS partners of Suffolk North East Essex are Ambulance Service, so East, East Suffolk North Essex Foundation Trust, ESNEFT, and West Suffolk Foundation Trust, and of course the ICB itself. The SNE system has an NHSE approved balanced financial plan, which is in line with our circa £2.5 billion of funding allocations. And between those system partners, West Suffolk have a board and NHSE approved £15.2 million deficit plan, which is offset by surpluses from the other partners in the system, predominantly the ICB. And the plan that we had agreed with them at the beginning of 2024-25 was that we would expect that deficit to be halved by 2025-26 and a balanced plan achieved by 2026-27. And I'll go through, I guess, where things are at the present time. So in summary, month 9, that's the period to the end of December. That's the ICB, East and ESNEFT are projecting that they're all on track to deliver their approved plans, noting the pressures and risks, some of which Alan's already expanded on, that we're working through, but for us also including rising costs associated with continuing healthcare, some really significant strategic developments that have been put in place in ESNEFT, including their implementation of a new electronic patient record, the new orthopaedic centre at Colchester Hospital, and a green surgical hub. And of course, ESNEFT are also having ongoing discussions with NHSE with respect to funding of the pay award, although that seems to have reduced down in materiality. So for SNE, really, the is our most significant financial risk for this and for next and future years, really, at the moment. The trust itself went significantly off track in the first quarter of this financial year, most significantly as a result of workforce control, implementation, delivery of the trust cost improvement plan. And at that point, at sort of July, August time, the position without mitigations would have been a likely trajectory that would left them with about £20 million off plan, or a sort of £35 million deficit. The trust put forward and implemented a recovery plan, setting a likely position of 28.5 million, so 13 million off plan, and that the implementation of that recovery plan, which was largely made up of enhanced grip and control measures, and improvements in the resourcing internally to deliver their cost improvement plan has resulted in a reduced monthly deficit. So there has been a noticeable improvement. And we've recently concluded an agreement with the trust for a £26.5 million deficit, which is £11 million off plan, but of course still significantly better than the position that we were looking at back in August. And that's in line with their month 9 year-to-date position of about £20 million year-to-date deficit. So the revised position for West Suffolk, including the compensating surpluses in the ICB, East and ESNEFT, means that SNE will deliver a balanced position in 2024-25. And the revised organisational forecasts were approved by the ICB board in January and subsequently by NHS England. And the system plan agreed follows a really extensive system recovery process that has meant the utilisation of non-recurrent flexibilities, decisions on investments held, and the full utilisation of existing system reserves. I'll talk a bit more about that in a second, but and then other measures that we've put in place have included additional delivery support within the trust and a new, more enhanced layer of pay and non-pay approvals from the ICB. That's known as double lock. Triple lock is where you're not in balance as a system, which is not the case in Suffolk, North East Essex. That involves NHSE involvement. And of course, there are straightforward financial implications in relation to this. The impact is also very significant in terms of people's resource and time. And most fundamentally, as a system, we're very aware of the opportunity costs associated with propping up one part of our acute system fundamentally, and our ability then to do some of the more strategic investments in new models of care, etc., that are at the core of the SNE ICB strategy, really. And we're also very mindful that the utilisation of non-recurrent flexibilities in this and actually the last year will have a really significant impact on our ability to work towards a balanced plan in 2025-26. To note also, the ICB, alongside West Suffolk Foundation Trust and ESNEFT, have jointly commissioned a sustainability review. So that was reported to our public board in January as well. That review is commencing at the moment, and it will examine how the acute and community providers could improve collaboration and integrate care to achieve the shift from acute to community, which is set out in the system's future shift strategy. The review will work through effectively what is in the ability of the trust to meet the future needs of the population within the expected funding allocations, and then what else needs to happen with respect to future configuration of services, new models of care that will enable us to live within our means for the future. I think just a quick word on planning expectations for 2025-26. So we're exactly like MSE and Herts and West, working through the full guidance, but it's pretty clear to us at the moment that it feels like a real terms funding reduction, which is going to require some very challenging trade-offs. The key areas of risk for us as we go into next year include the ongoing issue with West Suffolk, the shortfall in elective funding, which Alan's already expanded on, and certainly not unique to Herts and West. It's a very significant issue for us. In particular, just to reiterate for SNE, in relation to some of those big increases in capacity for elective care and orthopedics as probably the biggest example. And to what extent is that actually going to be funded for from 25-26 onwards? On the other side of the ledger, I suppose we have been given more flexibility within our funding arrangements to support this. Not all of those are going to be realisable in next year, but could benefit for us in future. And we also expect the capital regime to be more supportive albeit with the caveat that the revenue support may not be there for to facilitate that. But the current assessment, I think, again, as Alan has already expanded on, really is that the risks outweigh the benefits as things stand. From a SNE perspective, we are working towards agreeing a balanced financial plan. That's very much our intention. But of course, there's an awful lot for us still to do, and likely to be some serious decisions on trade-offs. But yeah, more to come. We're working through the implications at the moment. Thank you.
Thank you, Howard. Members.
Thank you, Chairman. Just in the reports that you've given, there were a couple of line items on prescribing or prescriptions, where I think HWE with 4.8 million overspend on prescriptions, and you see SNE is 1.6 million. Could you explain the drivers behind that?
So I'll go first. So whenever you look at actual spend versus budget, there are two things you need to think about. One is how much does spend change by, how much to change the budget by. So we were quite bullish at the beginning of the year because we'd had some new drugs, so all anticoagulants, new range of drugs coming off patent. There were big price reductions that started in 23, 24 that would have a full year impact in 24, 5. So we set a very aggressive budget. What then happened is that there became a shortage in some of those drugs, and so the prices we pay are set nationally. When there's a drug shortage, often actually they'll set a concession price which is higher. So some of those savings didn't come to fruition. However, when you look at our spending over the April to November of 24/5 compared to 23/4, our spending is pretty flat. So actually what we've got is hardly any increase, even though there's new nice technology products that come in, so new drugs we have to prescribe. And also we're targeting certain conditions where we think there's currently under-prescribing. All of that, our prescribing costs are pretty much the same as the year before. It's just that we set, in hindsight, you could say a budget that was too aggressive. That's why we've got an overspend.
Councillor Spencerley.
So I've got a question for Mr. Abel. So you can see where I come from. Yes, yeah. Okay, so my question is actually around, we were talking about sort of lessons learned really going forward with regard to what are the drivers of the cost, which you touched upon with bank and agency stuff, but I wondered if you could sort of expand on your perception of those drivers a little more. And then you talked about the medium-term plan, which of course we've all got to look forward to coming here for us to see. But you also talked there about what services look like. And so my obvious question is going to be, will accessibility truly be a part of that? And the reason I raise this is because, you know, for example, the little example of my own ward, where one half of the one LSOA, the residents there are among the 10% worst off nationally for access to services, which includes NHS services. And you know, that question of accessibility to services, I think, can sometimes, there can seem to be solutions that maybe aren't as straightforward as they seem. One of the things that I know has come out of the working group has been that the ICB has been investing more in local GP technologies. Unfortunately, I've had some residents this week who've had an experience that the surgeries are actually frightened to use those technologies because of the very ageing population that we have in the area. So I just wondered if you could talk to any of that for me. Thank you.
Yeah, of course. So if I'll talk first around the sort of the big cost drivers that we've got within the Mid and South Essex system. So, and I guess you have to see it in the context of the previous year. as well. So in undertaking, I obviously wasn't here at the time, but in undertaking planning for the current financial year, the system looked at, well, what's the current run rate? So how much are we currently spending on the delivery of healthcare? That included an element of premium staffing. So in effect, where there's vacancies or increased demand, effectively putting in staff, temporary staff, through one form or another. And there's two broad ways you do that. One is by using a provider's own bank, which can be a mix of their existing employees doing some more hours, as well as people who just want to work a bank contract, and then which is slightly more expensive, or agency, which is significantly more expensive than that. The plan assumed for this year that there would be quite a rapid and significant reduction in the utilisation of those staff, and through two routes. One route being some additional substantive recruitment. So in effect, we've got more permanent staff, and so which are cheaper than temporary staff. And secondly, also the various schemes to manage activity or reduce the demand for staff would kick in. So to give you an example around that, there was assumptions made that the average length of stay within hospital would reduce through a combination of things which the hospital could do and things that the broader NHS and care system could do to support it. And by reducing length of stay, you reduce the number of beds you need, and therefore you reduce the number of staff you need to staff those beds, which didn't come to fruition. And hasn't come to fruition at the speed at which was planned for the official plan, which is why we saw the significant deterioration, I think, in the first 6-month period particularly. And what we have seen subsequent to that is we obviously have seen some improvement, particularly in the hospital. So they have improved by over £1 million in the last month against their plan, and we have seen really good progress around, say, delayed discharges. So the work we've done across the system over the winter has seen the lowest level of delayed discharges we've had since 2021 when we started recording, and that's fantastic work between health, social care, etc. to achieve that. So I think there's a question about whether the original plan's credible or not, and that's what we're going to have to challenge ourselves really hard about going into 25-26. It probably was the right plan, but actually, could it actually be done in the speed at which the plan implied? And we need to stress test that going into next year. In terms of new models of care, yes, so I think accessibility has got to be key as part of that. And if you look at the kind of the three big shifts that the government has been talking about around healthcare, one of those is around acute to community, which implies how can we provide care better in local communities. And that is going to require some changes in the way that the NHS currently works. And so thinking about Malden, the conversation about how can we make sure that we've got the right ambulatory care provision within Malden through the existing outpatients and diagnostic services. What opportunities do we have to integrate that into general practice? And so actually there's a wider team approach in terms of the way that services operate. And indeed, what is it we can do around looking at some of the conversation we're having through the working group around the bed base and thinking more innovatively around that. And I think we've got some really great suggestions going through be able to do that in a way so we can get people care closer to home in a way that's affordable and of good quality, and that's what we want. So that's got to be a key component of that. And we do need to look at working with, so obviously there's a lot of new technology which has gone into general practice over the course of the last year or so about how in doing that do we not exclude certain cohorts of the population who aren't able to use that and don't want to use that. And so I think I know there's a lot of, well, I know there's been a couple of implementations which we're still working on in Malden specifically, where probably there's a lot of learning and could have been done better in retrospect. And so do continue to feed those in actually to us, because it'd be helpful to get the feedback and continue to support the practices with their digital rollout.
Thank you. Thank you very much.
Councillor Harris?
Yes, thank you, Chair. Thank you very much. Thanks for the 3 reports. As a general comment, Chair, if you don't mind me saying to start off with, is there a national standard for presenting these sort of reports that you will have to conform to, or do you create your own? Because I see there's marked difference between the 3 reports. There's red and green on one, and lots more detail in others, and spreadsheets and etc. Macros, of course. So that's the first question, which I'm hoping is easily answered. The second question is about MID. We have monthly reports, don't we, Chair, about every month about updates on cancer numbers, elective care numbers, window pressures, and there's a whole summary of things. And one of those is finance, and the finance for this month, for example, illustrates the figures you were talking about, the reduction in staff from 17,309 down to 16,379. That's 1,000 less staff. And I see why you're doing that because of the deficit, etc., and the improvement value target relationship. Bearing in mind, and this is the crux of the question, bearing in mind the stats and how we're performing, is there a definite, you're talking about how the staff can work more efficiently to achieve the end result with less. Is there a limit before you can say you can no longer do that with the monies that you've got there? Because I was really concerned about looking forward about how you can deliver that and deliver that with what you've got. Is there a time that you will go to and say, I need more to do that because we've achieved all the efficiency we can do? And how would you judge that? That's to MID, first of all. Do you want me to stop there, Chair? Because I've got questions for NHS.
You carry on.
Okay. So on the Suffolk and North East Essex, the plan for month 9 is green all the way down the page, which is good because you're all within those things, and you've allocated some of the risks. I saw that, but is that sort of measured monthly with those red, amber, greens, so you can actually see those are starting to go the wrong way and do a stitch in time before the inevitable happens? You're obviously managing those figures, and that's really the question about whether those are regulated or looked at often enough in enough time scale to be able to take action. Thank you, Chair.
Alice, do you want to go first, and I can come back on that?
Howard?
Yeah, of course. Yeah, I mean the green bit relates predominantly to the ICB's position as opposed to the whole system's position. I mean, I think I'm not going to expand any more on the sort of significant risks in relation to West Suffolk. But to answer your question, yes, we monitor that monthly, and there is, I would say, significant scrutiny given to not just the ICB position, but also the system. You know, the ESNEFT, West Suffolk, and EE's positions as well through, we have a system finance committee that includes non-executives from both the ICB and from ESNEFT and from West Suffolk as well, and that meets monthly. Yeah, and I can assure you that that meeting gives a proper tire kicking basically on positions, etc., as you would expect and want. Yeah.
Thank you, Chair.
So I'll answer the other points. So I think I'm right in saying, Alan, there isn't sort of a standard. Well, there's sort of standard submissions.
Shall I do that? So there are standard reports that trusts and ICBs have to report to NHS England. If we'd have given you those, well, I don't understand half of what's in there, if I'm honest. And actually, what we're all doing is we're trying to take what is loads of data to try and distill it down into what are the most important things. And some of us are better than others. My take-home message from this is have a look at the good stuff that Mid, South and SNE are doing at Nicky, because it's really challenging to take a complex set of information and make it easily understandable. And so we try and cut down and cut down and cut down, and sometimes we miss things that people find important and interesting. So yeah, we can always improve, but this is a massively cut down version of what we have to submit to Managers England.
But if this is a thing this committee wants to keep an eye on, it might be worth us doing a bit of work outside the meeting, say this is what we really would like to see, and we can try and think of a way if we can do a consistent buying report, if that makes sense. So that might be something we could work off outside this meeting if this is something we're going to want to keep looking at. I can understand, try and make the 3 reports make sense. You know, it's on your the second point around kind of tipping point, I guess, in terms of, so when does the finance and the staffing implications of the finance tip into sort of quality, safety and performance of service? There definitely is one, and so we do have kind of quality surveillance arrangements in place to try and keep an eye on that. And however, I think what is clear, speaking from Mid and South Wales, is that we have a health system in that part of the world that is fundamentally not financially sustainable, and hasn't been for some time. And so, yes, so far we can go with waste in terms of productivity and things like that. And then the next steps on that journey are going to have to be two parts. So one is a conversation in terms of what is deliverable with the resource that we have. But the second is also how are we going to need to change the way that services work more fundamentally to reduce reliance on hospital services as the most expensive component of care. So trying to give an example of this. So for instance, diabetes actually. So diabetes is an area that we are picking up. So in some parts, particularly the southwest of Essex, we have relatively poor control of control of diabetes in terms of, so actually if you look at outcome measures around diabetes, then they aren't as good as they need to be. And a lot of that's delivered through primary care and our community services. We know if you don't control diabetes well, people are much more likely to end up being admitted to the hospital, people are much more likely to have an amputation of some form, and will end up potentially getting much longer term care needs, all of which are very expensive and obviously really bad for that person and their family. And so we also need to focus on those things that we know that we can do to help support people, particularly with long-term conditions, to live happier, better lives. So we reduce that reliance over the coming years. Because if we don't do that, we're just not going to be able to get the system onto a more financially sustainable footing. And I think ultimately, my vision I've reached is, my limited understanding of, government's financial position. There isn't a lot more money that can be spent on the health service. So we are how we work differently from the current model that we've got right now. And we'll be talking about some of that in our medium-term plan when we come back to talk about that.
Chair, I think that's refreshingly honest. Thank you, Tom, and thanks for that was the first time I've heard those words really, and that not financially sustainable, that can do differently. And I think that was and I think the committee ought to salute those remarks and applaud the work that we're trying to do to match the needs, as it were.
Thank you, Chairman. I just trying to look at a little bit at the bigger overall picture, and wondered if I could ask how Essex does in terms of budget and comparing with other counties in terms of budget spent per person and the capital spend per person across the board. I just wondered if you could just do some of that comparison.
So I'll come in first there. So there is helpfully a toolkit that NHS England provides that enables us to group together practices within places. So we're able to then say, for parts of West Essex, what should the target share of funding be for our 3 places are West Essex, East and North Hertfordshire and West Hertfordshire. So what should their target share be and what they're currently spending? All 3 of our places are over target. we spend more than our target share, all by more than 2.5%. I think as an ICB in total, we're about 3% and a bit overfunded based on the formula. Debate whether the formula is the right formula. Ahead of population, we spend less, but ahead of the weighted population as calculated by the formula, we spend more.
Yeah, it's the same for Mid and South Essex. I think the slight challenge with the formula is and has been for well, at least the last 17 years I've been in the health service, is that the way the weighted formula operates is it looks at issues of, say, around deprivation and factors like that, and so will effectively give you more money. It's my understanding in that situation. The slight challenge with that is that actually areas with higher deprivation generally have lower life expectancy.
Yeah.
And actually, we know that significant portion of your healthcare costs are incurred as you get older in life, and so there is a challenge around how the formula currently operates in terms of it's completely the right thing to do, but how do you square that off against the fact that actually the significant portion of costs incurred by the health service for people who are older in life aren't kind of reflected necessarily within the way that the formula operates. And so it is a challenge for us because we're slightly overfunded as well in comparison to the way that the number that the formula spits out.
Can I just, what's the overall budget, the NHS budget for Essex?
Three together, I suppose. Yes.
So we are 2.7 billion.
So if you include all of the elements, we're about 3.7 billion, of which about 20% would be West Essex.
Okay, so that shows that we're less than half of the spend per person, given the national NHS budget is around 190, 200 billion. Okay, so we're spending half of the national average in Essex. That doesn't quite tally with what you just told us.
Well, okay, so I'm not sure that is correct. I mean, obviously there's a little bit, there's an element of SNE that covers North East Essex. But, so as I said at the beginning, NHS England is part of the equation. They receive the full allocation and they pass an element of it on to ICBs. There is an element that NHS England still commissions. So the higher end of specialist commissioning, we don't get. It's managed by NHS England. Health elements, vaccination programs are essentially managed by NHS England. Health and justice is NHS England, not us. So we don't, as ICBs collectively, get 100% of the NHS England budget. We only get part of it. So we can only compare ourselves to other ICBs. And are we better funded or worse funded? I think we'll probably all be in a situation where if you just divided the money by the total population, gave everybody the same amount per head of population, we would get more funding. If you take into account the formula, which is supposed to lead to equal funding, equal need, we are seen to be more needy than the average in the country. So we get a lower target based on that need.
Is that need or efficiency? I mean, are we being penalised because we're more efficient in Essex in delivering those services and therefore we're given less money to provide those services? Or is it directly related to the need that we have here?
It's supposed to be needs-based.
So it's basically the formula works on demographics effectively in individual communities. So we'll look at age, deprivation levels, income levels, etc., etc. So that's the way that the formula operates. And so yes, so effectively that will the formula sort of incentivize, well, allocate more to say some kind of those areas which have higher levels of deprivation and inequality.
Are those KPIs presented somewhere? I mean, I wasn't able to find them when looking for them yesterday, and it would be helpful to have some indication of that. But I did, as I said, a quick back of the envelope calculation and came out with less than half of the national average per person, and that was surprising to me, given the depredation indicators, and I was trying to balance that and wasn't able to find that information. So that would be extremely helpful.
Okay. Howard, was there anything on that particular question that you wanted to add in?
I mean, up until last year, Suffolk, North East Essex, so 2.5 billion, say a third of that roughly would relate to North East Essex. Up until last year, we were basically at our funding allocation, our fair share of the national funding allocation, but they've shifted the formula a little bit for this year. So I think at the moment, off the top of my head, I think it's about 1.5, 1.4, 1.5% over our target allocation currently. So not quite to the same extent as Herts and West and MSE. If I looked at out of hospital services, so how do we benchmark nationally against our spend on continuing healthcare, prescribing, for example, primary care? It looks like we're at or below sort of national spend levels. It's a good question then about the link to productivity and what's happening with that money. I think our problem at the moment is that we're spending more than we should be on the acute sector, and that's fundamentally what we're trying to get underneath with the sustainability review that we've recently commissioned. So basically, as a proportion of spend, immediately after COVID, I think it was maybe 53% of our total allocation would have gone on acute services, and at the moment we're up to about 57%. A lot of that, of course, is in part non-recurrent because of the additional work that's been going on, for example, around elective recovery funding and so on. But there's no doubting the trajectory is sort of counter to the strategy that we're actually trying to implement at the moment.
Thank you. Caroline, any questions?
If I may, yes, thank you, Chair. And it's a question perhaps for Alan and for Tom. I think I heard you, Alan, say that you referred to to MSE Trust, and there had been improvement. What more are you wanting?
Well, maybe I'll answer it, because obviously we host the system. We need to see a continuation of it, Caroline, in short. We can't consistently live above our means in the health service in terms of our finances. It's not fair on taxpayers, and it's not fair on the communities that we serve collectively. So what we need to see is we need to see continuation of the improvement we've already seen, and there's been some good work. It's been some very good work. But recognising the fact that the hospital can only control so much. And so then alongside that, the other thing that we need to do is, and we'll need the hospital's help in doing this, is what can we do in order to prevent people requiring hospital services? And the big challenge for us all within the health service, and we talked about it at the Health Wellbeing Board last week as well, is how can we turn those words that we have been saying repeatedly for many, many years into actual delivery and action. And that's got to be the challenge that we've all got to take on, and we have to collectively respond to. So that would be my request, Caroline.
Continuation.
Yeah.
Thank you.
Okay, so I guess for my part, I have the very fortunate position of chairing this, and we're now coming up to our 4th year on this. So if I want answers, I can go and knock on a door, and this little bit of plastic will quite often open the door and get me in. In fact, I've got another one that will literally open the door. So it's not difficult for me to understand what the system's trying to do, what it's trying to achieve. But it is neither easy or my place to explain that to the residents that elect me and those that didn't either, and they don't get it, they don't understand. They can't go into their health centre, the local doctor's surgery, and they see somebody carrying out yoga. That's not something that they used to see. They used to be able to see a doctor, or they used to be able to see a district nurse, or have a blood test in the local doctors. And now we have what feels like an overcautious 111 number, and an insane amount of people who've spent the weekend worrying the life out of themselves, looking up what symptoms are on Google, and they're heading straight for that number with a whole different language base than they had before they first found the lump or the headache or the ache. And suddenly they're all presenting. And I've got Basildon Hospital with a catchment area with some of the highest levels of deprivation in the country, in my own. 500 people sitting in an ED department that was built for 250 over a 24-hour period. And so I don't care what the size of the envelope is at the start of the year or even at the end of the year. I just want to know, is it going on? What's delivering the services that people want and that people need? And one of the continuous issues that I've had for the 4 years I've chaired this is that nobody really is communicating that with patients. We're doing an awful lot of social media stuff, but that aging population that we've talked about are not necessarily social media savvy. They're not seeing that. Yet we have, this council has over 70 libraries. Every one of them has public access computers and staff. We've got doctor surgeries. We're paid 14 councils and a county authority, God knows how many community buildings that we like to take advantage of, and even seed fund services in there that will actually help with well-being and aspects like that. And somehow still people 2-3 years on don't know why they can't see the doctor, and nobody seems to explain it. And sometimes when I have people in this room here, they don't explain it to us either, because they say, but we're doing this. And it's like, yeah, but the day job is this. The patient thinks the day job is this, and they love that they can do yoga, but they can do that at the library, or they can do that at the this is the doctor's surgery, and you've got this and not what they've been used to. I understand the change, I understand the waste. People are frustrated as all holy hell, and they just, my concern is that people are being missed, or the people that don't want to be a bother. You've already got that anyway. We already know that in levels of high deprivation, engagement is incredibly difficult. So getting those people to trust clinicians is very difficult. So it's really important that we do something different. So I'm asking, and maybe giving you can address that, any of you, if you want to, set you some homework. So I've got 1 chief executive and 2 finance officers. I assume I've got 3 of each of you. So my homework would be, if you don't mind, what's the silver bullet for the golden gun? We're quite happy, as we've done 4 years as committee with me, and we've had very similar things, and there are updates on very similar themes. And we want to know, what is it you need? Because we do appear to have a government that's quite prepared to open a drawer and chuck a stick of dynamite in and close it quickly. So if we've got a government in the mood to shake things up, what is it that makes the difference to you guys? What helps you do the day job? So what do you need from us? You don't have to answer that.
It's good homework.
Yeah.
So go on, Alan.
I don't.
Come together.
Yeah, I'm a glutton for silences and wanting to fill it. So my wife's a GP, and she reacts whenever we watch television. We don't watch much of it, but an advert comes on and it says, if you've had this or think this or do, go and consult your GP. Yeah. And it's kind of, oh my God, no. And because often it's not really the right thing. So there is something about national media and campaigns actually doing the right things. One we were involved in, which people may have seen, and it was about blood pressure. So we've got this big push about know your numbers, because high blood pressure, major problem. You don't know if you've got it or not, because there are no easy symptoms to see. So, we started rolling out blood pressure monitoring in outpatient departments, done it in dentists, in optometrists, and so on, because it's one of the key things. The other thing is, I heard it that sitting is the new smoking. So, exercise. Eat the right things, but exercise is key. not just because you might lose weight, but exercising the body actually helps, just general the body's wellness. And so there is a bit about the partnership that we can all have with our population to truly really understand how to stay healthy. And I don't think any of us really want to use the NHS because that usually we use it when we're not well. But how do we really push that prevention agenda, and not the prevention agenda that's like 15 years down the line, but the things here and now that people can do to stay healthier and need to use the NHS less. And the other bit I think is, it was touched on a little bit earlier, we've still got an NHS that is working as if it's always something new. Let's wait and see what it can do before we get too involved in it. It's a massive change in the way population engages with the NHS. So the NHS app, I think a lot of people downloaded it during COVID. I think it's fantastic, but there's more we can do. How do we work on the basis that probably 80+% of the population are digitally savvy, and more so than I am? How do we create something that works for the 80% at the same time as making sure the 20% don't get left behind? It's just a different mindset, but a partnership. I think that we aren't there doing stuff to people. We're working with people to do the things that they need, one of the same as the things that they want.
You talked about cap on elective funding. How do we square that against, for example, Mid and South Essex Foundation Trust have a target for their operations and waiting list? So they have a target of a percentage. It's a percentage number that's the national target that they must hit, and they're currently here performing above it or below it. How do you square that in terms of, and juxtapose that against the fact that we have gone crazy on CDCs and diagnosing early, so we know more about how many people we've got sick?
So apples on funding. I think the interesting that the government view is that you don't need as much funding to do the work, you can do it more efficiently. That's a real challenge, but that's in effect what they say, because the performance standard isn't necessarily about doing more work, it's about increasing the proportion of the population that get treated within 18 weeks. So if you can actually intervene earlier and you avoid the need to actually intervene because you've got better diagnosis, advice and guidance at the front end, which means you're not taking up hospital capacity to see patients because you can sort their problem out without seeing them. The view then you're creating more capacity to then do treatments. And then if you target your treatments by reducing the long waiters, I think we've currently got a mixture of some very, very, very short waits. We probably need to be doing a bit of short-term disinvestment where waits are really short to put more funds into where they're longer. And that probably upsets some people if they have been working on, the more they grow their business, the more money they get. We're going to have to start to put a lid on that, because I don't think it's right for a part of the population to be seen within, say, 6 or 8 weeks, and the majority of the population having to wait. Obviously, that's not for clinically urgent patients. These are less urgent. They need to be seen in a timely fashion. We need to be equalising that. I suspect the same is true in most parts of the country. So there'll be a bit of that.
I'm seeing nodding from Howard and Tom as well. You talked also about funding that you've got single-year effective settlement. What would that look like if it's multiple years? Would that, surely the councils, when we do planning here, certainly we put together a 4-year plan and we put together a budget, although we come back obviously every year with a financial budget for the year ahead. It's based on a 4-year plan. the fact that you're not able to do that seems a little counterproductive, especially when you're then sitting there or losing money at the end.
I mean, we can do it. Our problem is that none of our income is guaranteed. You might say, well, nobody's income is guaranteed, but we have to make estimates about what funding we'll get in future years. And we did our full year plan back in September. We were saying that we would have a deficit in 25/6, and we wouldn't get back into balance until I think it was year 3 or 4. Now that at the time we were part of the discussions and negotiations with NHS England that says there isn't enough money in the system. Response 25/6 is the money, and you've got to make it work. You've got to generate greater efficiencies, and you've got to make some choices to live within the money. So we do plan, but the plans are on shakier foundations, I would say, because 99% of our income is just waiting for the allocation to come out. There's yet to be a year where the allocation has gone down, but we have often seen real terms, flat cash, and this year's probably negative. That probably is the first time that's happened.
Yeah, I think the other thing, obviously, that it's you don't have certainty around the cash, but actually the other thing you don't have certainty about is what's expected to be delivered with that money. You see what I mean in terms of, so actually is the priority active care? Is it cancer? Is it urgent emergency care? Is it reform of general practice? Do you see what I mean in terms of, and we only really get certainty around that when the planning guidance comes out. And last year it was March, this year it's February, and then the financial year starts in April. And so it is, actually, trying to move. And I think, there has been commitments to try and start to do this earlier and start to kind of set out kind of a longer term sort of ambition for the NHS. But I think that chopping and changing doesn't help either, because you have to kind of, you're not just generally thinking about the money, but also thinking about, well, how do you then organise yourselves around the delivery of the priority for next year at relatively short notice. So more stability in that's obviously incredibly helpful. Then you can start to think about how do you make the right strategic investments to deliver on those objectives over the medium term. And I don't know if this committee has seen the most recent kind of public accounts committee report on questions of NHS finance and planning processes, but there's a lot of findings around kind of these issues, within that report as well. So, so I think it is something that's acknowledged and recognised, but to try and hopefully continue to work to see that actually happen, because that would obviously be hugely helpful for everybody involved.
Thank you. I've been a councillor for 8 years, and I think it used to be that we'd start talking about setting next year's budget sometime around October, and we'd always wait for that government settlement around Christmas, and then you'd have a budget meeting in February. And now that budget meeting and those conversations about budgets and finances start happening earlier and earlier each year, to now that they're a point of punctuation in every conversation, and it's just the footnote to everything we talk about. So I wish you well. It feels clunky that you go year by year. It doesn't feel a particularly secure environment, because you're not just balancing what you can do, but you're balancing then capacity to do it as well in many ways. So your homework is to work together, the three of you and your counterparts, and tell me what would be the thing if you had a HOSC for a whole county writing to the Prime Minister or Health Minister or whoever on your behalf to ask for one thing. What's the ask? Because it's kind of frustrating. I get that we're all in the same boat, so thank you. I did have one more question about, and I'm not sure who that is, it's Alan. One more question about Princess Alexandria. We had Michael Meredith here a while back. Councillor Harris and I went to have a look at Harlow Hospital We can see the need, we can see the benefits, we saw the plans. The man will talk your leg off, and he's a great performer here in this room in terms of making the case for it. We believe they've adequately done that, but we've now got more slippage, what appears to be more slippage. It's not going to be done in this Parliament, it's actually more than the next Parliament when it starts. And is there anything that can be done to make sure that that isn't kicked further down the road? Or was a hospital?
Yeah. So the good news is it's still in the programme. We've actually got two, because we've got Watford as well, both of which have been pushed further down. I think on both of them, we're still trying to push for them to be ready. Because if the worst thing that could happen is that we take our foot off the gas, we sit and we wait, and then suddenly somebody decides that there's more money available, and then we're not ready for it. So we want to be putting pressure to make sure that we're ready to start when the funds become available, whatever that might be. I think one of the downsides on the PH scheme is that there isn't a site that is owned. But I think there are two sites that are being considered. So I think that was a reason why they pushed into the second wave. So that needs to be resolved quite quickly. And I think there are issues with both sides that need to get pushed on. Otherwise, we're not in the ready to dig kind of scenario. I think it's becoming more and more challenging. It's more and more difficult to keep services running on sites which are becoming less and less able to cope. We have restrictions around flights because the electricity substation doesn't have enough capacity. Things I'd never even think about. Now suddenly coming live.
Isn't it part of that building work at Colchester was a substation to power the thing?
And so the danger also is that we would need to keep the hospitals going is going to increase as they start to fail more and more, but we're not necessarily going to get any more capital in the meantime. So it's a massive challenge. But when you said earlier about the silver bullet with the golden gun, I was say new hospital programs. I thought, no, that's too acute-centric, and we can talk more about what we can do outside of acute services, but that is a massive challenge.
I mean, I think when Councillor Harris and I we went there and we were having a look at it, and it's like, you can see that it's been repurposed to death and just reimagined and reinvigorated and uninvigorated to death. There's literally not another thing you can do with it. One of the biggest issues is accommodation for nurses of other backgrounds, and yet we've got office blocks that could go almost anywhere in what was accommodation. And then I look at us in hospital, and we've got accommodation blocks sitting almost derelict. And I think, how do we get the money in? We could have a memorandum of understanding with the council to do some of their homeless or something, and let them take on the maintenance and the cost of that for a couple of years. Something, anything. But it's really, really difficult. It's very frustrating that the site hasn't been procured as well, because as Tom said, you haven't been here at the budget setting of this year. And maybe you're looking at some of those things and it's going to be a decision I would have made. And would we get that if we have a change in government? If we have, as I said, this is now plotted for more than halfway through the next Parliament. So it's just frustrating. But okay, thank you. Homework is set.
He hasn't said what it's due anymore.
Thank you.
Thank you.
Thank you.
We're back. Lovely. Okay, thank you, members. We'll now move on to item 5, which is the Mid and South Essex Foundation Trust maternity response to the CQC report. So with us today is Diane Sarker, who's Chief Nursing and Quality Officer, and Paula Hollis, Head of Midwifery.
Thank you, and thank you very much for inviting us. So I thought I would just do a very brief introduction in terms of where we are at, and then I will hand over to Paula, who's the Head of Midwifery, who can describe to you some of the changes that have been made and some of the progress that has been seen, which is really positive. So we had an unannounced CQC inspection back in March of last year. Feels a very long time ago now, doesn't it? March last year. They inspected our 3 hospital maternity units, so Basildon, Southend and Broomfield. We have only just received the reports from those 3 inspections in January. And Southend and Basildon requires improvement, and it was pleasing to note that Basildon had their section 31 removed, so that was really good progress. Broomfield had a report of requires improvement in the March inspection, which was extremely, obviously, disappointing. There were a number of key areas that Paula will talk through from that inspection. But since that inspection, the CQC came back in July and re-inspected the progress that had been made, and that report is due to be published tomorrow. I am pleased to say that it is no longer inadequate and it has moved to requires improvement. So that report is being published tomorrow. But I will hand over to Paula to talk you through some of the key findings from the March inspection, and more importantly, the actions that have been taken.
So I'm Paula. I'm now the Head of Midwifery on the Broomfield site. I only joined Broomfield in July following I think I actually started the day before the repeat inspection, having worked for 5 years on the Southend site. So I was able to bring to Broomfield the experience of being a previous Head of Midwifery. And also I had worked on the Broomfield site for a number of years, going back in the 2000s. So the report, when it was published, or the feedback that Broomfield got at the time is in your paper. There was concerns with the triage and the day assessment unit around risk assessments and escalations, our induction of labour procedures and caesarean sections, and what we call modified early warning score system, which is basically undertaking observations on mothers' blood pressure, pulse, and when these are undertaken, a score is attributed, and that gives you an indication of when you should be escalating. And there was also some concerns around equipment. When I joined Broomfield in July, a lot of these actions had already been actioned, for want of a better word. So the triage system, one of the findings was that there wasn't a dedicated phone line for mums to phone in. So the phone line when women would phone in maternity was on the ward. So how quickly that was very dependent on the activity of the ward. And there's a national triage pathway that was set out from Birmingham that we all have signed up to now. So there is now a dedicated phone line for mothers to ring between 8 and 8 in the morning, 8 and 8 in the day. Overnight, it goes back to the ward, but activity isn't as busy overnight, having undertaken, we see a lull in triage phone calls there. So not only do we have this dedicated phone line, we're also adhering to national guidance in how we answer it and how we RAG rate it. And all the staff that undertake that have to have a certain amount of experience and a certain amount of training. So that was actually put in place before I came. That started in April, May time. That's one of the, we report the findings of that every month. So audits are undertaken, how quickly are the phones answered, what happens to the women, are they triaged in the correct way? And I'm very happy to report that month on month the audits are always compliant. So it's very embedded into the system now. So when the CQC came back in July, that was one of the areas they felt very confident that we'd really made steps to improve. One of the challenges that was happening on the Broomfield site was it was almost like Broomfield maternity become a bit of a victim of their own success, because a lot of women that lived outside of the actual catchment area wanted to come to Broomfield to have their babies. They'd had them historically, they'd had friends, family. So we had a look at the amount of requests to come to Broomfield, and what we're doing now, we're kind of managing our own women first and foremost. So people that live in this area obviously are entitled to come to Broomfield for care, but there may be ladies that live outside of the area that want to come to Broomfield. So we will only accept additional people if we have the capacity. So, and actually we've just finished a piece of work yesterday looking at what areas there are, and we decline 50 to 60 out of areas every single month that want to come to Broomfield. Yeah.
Just as your, could you define what out of area is?
Yeah, certainly.
So we've got issues over in Malden.
Yeah, so now I think I was just scouting the room and looking, so all of that comes under us. So out of area would be, so our three biggest out of areas that want to come to us, Billericay, that sits in the Basildon area, Brentwood, and Hutton/Shenfield. They both sit under Queen's. So it's out of, I'm probably not describing it very well, but it's kind of outside of that border. And that is the vast majority. So when the piece of work we did, we looked back over the last year, and I think it's over 60% of the women that want to come from out of areas come from these three areas at the moment. We've obviously, because Billericay sits under Basildon, we've obviously done quite a lot of work with our Basildon colleagues anyway. I think with Billericay, the distance between coming to Broomfield and going to Basildon is sort of equidistance anyway. I think Basildon for a little while was still suffering from some bad press from previous years. So there's been a lot of work to turn that around, and this new CQC report will go forward to support all the work that's done there. And we are in talks with our counterparts at Queen's as well about why do they want to come to Broomfield when there's a maternity hospital at Queen's. And I think I have to say again, Queen's also went through a period of not very good press as well, because they had a lot of issues there. So I think that's probably the key to everything that we looked at. Also, I mean, we've done so much work on this. We also looked at when Broomfield was built, and at the time it was built, the maternity unit was built with the anticipation of between 3,800 and 4,000 births, and at its peak Broomfield was seeing 4,800 women. So the maths is there really. And also complexities have changed. We've got much higher caesarean section rates, which mean women stay in hospital for much longer. So we've had to go back and review all of that, and how our service now needs to look with what we can bring into it and safely care for. So that was the sort of piece of work where the CQC had raised about inductions and caesarean sections. And it wasn't that the care wasn't there, it was that they were often being delayed. So from a safety issue, there wasn't a huge correlation with, and there still isn't, delay in caesareans and inductions. But there was a huge patient experience that people would come in and we weren't able to go ahead with their induction because we basically didn't have the beds to be able to bring them to labour ward. So there's been quite a change. We're not at the end of that journey. There's still work to do. And we've been working with, there's expansion space within maternity in Broomfield. But obviously, along with expansion pace is money as well. So we're looking at how we can open up that expansion place to increase our bed base. It's not so much to do with increasing our delivery rate, it's the fact that ladies need to stay in hospital for longer. So there won't be an implication on staffing because the numbers of births won't need to return. And we've just this week been told that we've had approval to go ahead with the design work. So that's the first foot on the ladder, but at least we're on the ladder now. So that's sort of really helpful. I report into the CQC every single month, every single induction or caesarean section that is needed to be delayed and the outcome of those. And over the months I've been in post, they've got less in time because we've put safety measures in place. We've done a huge amount of work for auditing our what I was calling the Muse charts, which is our basic observations, making sure that they're filled in properly, and also that when there is a trigger to escalate, not only is the escalation taking place, but the response to the escalation is correct. And we audit those every month. And again, we're feeding those into the CQC. And the equipment, when the CQC came, there were concerns that some of the equipment hadn't been checked and was the check was out of date. So it didn't mean that the equipment wasn't usable. It just meant that you should have an annual check, and they found several pieces of equipment where that hadn't happened. So every single piece of equipment in the maternity unit was checked, and they're all within anything that was found that needed a tweak to it or replacing, that happened. There's a very sort of obvious pathway now about reporting equipment, following up equipment, and just closing the loop. And again, we look at that every month now, and we've got lots and lots of evidence of how that's happened. So they were our main issues that the CQC had picked up on. And we are in a much, much better place.
Just to conclude, on the basis of the report that's going to be published tomorrow, we will be looking at our compliance with the actions, the conditions that the CQC imposed on us to request removal of the Section 31 notice. So that will be the next stage after the publication of the report tomorrow.
Can I just, I mean, there's two things before I open it up to other members. There's two things I wanted to ask. Firstly, on the equipment checks, is there a common practice on how those are checked? I've spent 10 years in opticians, and there's a couple of pieces of equipment we would hardly use, but every month a clinical optician has to check the Goldman's contact tonometer in the Perkins, because we're going to need them sometime, certainly pre-reg, but they have to be checked, even though they're rarely used. Do you now have that in place?
Yes, so I think the equipment falls into two halves. So there's the equipment that we use day in, day out, and there's daily checks on those every day. And you know, we have those checklists for assurance. And then there's the equipment like you're speaking about. So those pieces of equipment need annual checks from our trust-wide, and that's the bit that's been tightened up.
But what about calibration?
Yeah, that's all part of it. Yeah, that's all part of it. Yeah.
Okay, and the other question I had was, you had your inadequate, that requires improvement in July, which is a huge turnaround, and actually, in a narrative, feels more like the maternity ward that several members of this panel went to see only a few months ago. What are we doing to make sure that we're sharing that with the other two acutes that have it, and other maternity services in community hospitals?
So there's quite the cross-site working is really well embedded. So we have a minimum twice a day, 9:30 and 4 o'clock, the 3 sites meet for a safety meeting. So from a perspective of activity. So if Broomfield were thinking we're really, really busy and we've got 4 ladies who we need to induce tomorrow, we will reach out to the other sites and say, actually, have you got any capacity to take these ladies? The same happens with our caesarean sections. It's cross-site. How many slots do we have? So it's a much slicker. We wouldn't be in a position where one site is sitting there with an empty caesarean section list and the other one are turning people away. We do have to take into account women's choice, and it may be a lady that, say, is in the Morton area, doesn't want to travel to Southend to have her baby. So then what happens is a risk assessment is put in place to say, actually, can this lady wait another 48 hours, 24 hours and be slotted in there? We also, our risk and governance, that each site is accountable for their own risk and governance that covers everything and anything. That's all fed into our divisional governance that happens once a month. So any good practice, any learning is part of it that we share. And also any safety alerts that happen on one site, that is shared immediately as well. We've got a director of midwifery that has oversight of the 3 sites as well, and we have a clinical director. So it's all shared with us.
Councillor Spenceley, I saw you.
Thank you. So just the first question that I'm going to come to, of course, is staffing and how you're doing with that. I mean, obviously, the background with St Peter's was that it was closed quite a lot, so the numbers that were given weren't really reflective because it was closed so that the staff could go to Broomfield. So that's obviously a question that I'm going to be interested in. The second thing that I've picked up on this, and of course we do have to wait for tomorrow's report to see all of that detail, I appreciate that, is the triage phone. As a mum of four, I think every time I was sort of caught in the middle of the night. So I'm a little bit worried about you know, what's the response for somebody who does go into labour overnight? You went through all of the things that you're doing with regard to making sure that people who answer the line are properly trained. Does that happen at night as well? So that's just another little question. And the other one that I have, I heard, and it was too fleeting for me to properly catch it, how many patients the Broomfield maternity unit was originally created for, and what's your throughput now?
Okay, so I'll start with the staffing. So at the moment, we are fully staffed, give or take 1 or 2 posts. We had a staffing review last year, and St Peter's, as I'm sure you're aware, it's not open to intrapartum care anyway, but that's not a decision taken purely on staffing. That's a decision taken on the fact the service has changed. So we're like to many other maternity units across the region and nationally. The caesarean section rate is now pushing 45–50%. So, but I know it's very sad from a midwife's perspective, it's very sad. But this is the world we're in. St Peter's doesn't cater for caesarean sections, so therefore, and Broomfield has been one of the very few services nationwide that has had 2 standalone birthing units. It's very unusual given the profile and the demographic of what maternity services have now to have 2, well, it's 3 birthing units because we have 1 based on the Broomfield site and 1 at WJC. So when we looked at the staffing review, the decision to not have intrapartum care at St Peter's wasn't driven by staffing levels, it was driven by service need. So all the activity that happens on the St Peter's site, all the daytime visits, all the clinics, they still run. We don't, I mean, I've been at Broomfield for 6 months. I've never had to ask a member of St Peter's staff to come over and support Broomfield in that time. At the moment, what the next step we're trying to do is enhance the profile of home births, particularly in the Morden area. So coming from somewhere like Southend, which has got a really robust home birth service, that's what I'm trying to bring over, because we still want the normality, and it's just trying to embed that back into the community as well. They obviously have the choice of going to Broomfield or WJC. With regards to triage, I probably didn't articulate that very well. So they've also improved the triage services. So there's the telephone triage service, which is somebody on the end of the phone to answer that initial call. And then there's 2 members of staff that actually are working on the triage, so they will receive the women when they first come in. So when we did all the number crunching and the deep diving, the number of phone calls that come in, particularly between 11 and 4, really bottoms out. You don't get that. The staff that work in triage, they are still trained to the same standard as well. So we have increased staffing in that area as well. What was your last question? Sorry.
Around the numbers.
Okay, yeah. So we're doing around about 4,200 births.
And it was built for?
Well, when you read the paper, it's a little bit ambiguous. It says between 3,800 with capacity to go up by another 400 or 500. So what it doesn't say is that regarding the expansion space that's built into the PFI build, or, you know, but at the moment we are managing the flow. I mean, to me, I've been there 6 months, it feels like a completely different unit. I mean, completely. Thank you.
Happy with that? Anyone else?
Just a question for Diane Sarker, if I may, and this goes back to the calibration issues that we discussed earlier. I've become aware of issues with blood screening service at Broomfield, particularly in respect to the blood sugar tests and things, and I understand that test reports have been given false high values for some time, and that this service will be closed until April. my particular concerns on how this has affected patients' treatments and diagnostics historically. And I'm also concerned about the time that it's been taken to rectify this and why we didn't spot it earlier.
Yeah, we are hoping to have the service up much sooner than that. By the 1st of March, we're hoping to have the service back up. We haven't, some of it is external to us. We haven't had any reported incidents so far. And obviously we monitor that on a daily basis of incidents that are reported. So we are just pushing for it still to be done by the 1st of March.
Can I ask how many tests are currently being rejected?
Do you want me to?
I don't know how many have been rejected.
So we haven't stopped service.
Yeah.
The service, so the service is exactly the same for the women. The difference is it's not being tested on the Broomfield site. Those samples are being sent over to Basildon.
There's large numbers being rejected at the moment. So people who've been given blood forms by their GP or other referral services are submitting blood samples for testing and having those tests rejected.
So the latest we had of that, so to go back to why we didn't notice it, so it was to do with the equipment. So it was Bedford Hospital, actually, they were using the same analyzer as, their lab was using the same analyzer as Broomfield, and it was flagged as a national safety alert. So we were using that. So when they've gone back and done all they've looked at everything over the past year, but it does appear that we seem to have a peak about 4 to 6 months ago when we think it might have affected. So the ladies that are out of the service, duty of candour was done by them from the staff, the lab, that they've had their babies. There's nothing we can change apart from an apology that the equipment wasn't working. The ones who were still in our service, we repeated those tests and sent them over to Basildon. And we got the new blood analyzer in the beginning of March, but straight away it was flagged that the issues were still there. So what happens now is that, as I say, the blood is being taken from the mothers and it's being sent over to Basildon. And this was probably only last week or the week before. It's interesting you saying about blood forms, because now communication has gone out to all the community midwives and the GP surgery that they need to have a sticker on them to say this is going over to Basildon. So it will come into the Broomfield lab and then it gets transferred over to the Basildon lab. So there's no change in service for the women. The one obviously is the cost implication for us because we're having to take something over to Basildon. And I think there was only about 30 to 40 results that needed to be repeated in the last couple of months. That's sort of roughly in my head. I can provide the samples. It wasn't a huge amount.
And outside of the midwifery service for more general routine testing, diabetic testing and that sort of thing, how many of those are being rejected and how many of those were giving false readings over the last year?
I don't know. I can certainly find out and come back to you.
I mean, it just seems that the high values were being reported for a long time, and there's a number of people who've gone back with high value diagnostics, and whether that's affected their treatment that they've been receiving, and gaps in monitoring high glucose levels going.
So look, we'll formulate that information around the press release that was sent out last week. We'll get a little bit more detail on what it is that you want. We'll bring it to, we'll bring certainly the response.
Really happy to provide that.
Rather than a whole report on it.
Thanks very much. Yeah, that's great.
45 to 50% C-section. It's incredible.
It's following the national trend. I have to say Broomfield were the lowest across the 3 sites last month, but it's still, we're all sitting in the same ballpark. And unfortunately, we foresaw this coming because one of the main indicators of a caesarean section is previous section. So the ladies that were having caesarean sections 3 years ago, 4 years ago, are now having subsequent babies, and they're planning for another caesarean section. The sad thing, speaking as a midwife, is the actual process of having a caesarean section is quite slick. They know most of the time when they're coming in, how long they're going to be in hospital for, and people, that's why, going back to your thing, I'm trying to drive an improvement in home birth services as well too.
And of course, those ladies stay in hospital longer, and that's where the capacity issues become greater.
Is there a clinical driver for this, or is this
Sometimes there are, but
Yeah, I think it's so multifactorial, which is why it's so hard to, there is some work being done actually across 3 sites, looking at the different, because we now have a criteria which is called the Robson criteria, which looks at the reasons why which cohort are having caesareans. Is it previous caesareans? Is it first-time mums? Is it how many are in labour? How many aren't in labour? Previous caesareans is really driving it. So there is a piece of work we need to do around education for women as well. I think from the Broomfield site, we need to get the flow better, because if the women are coming in and induction, they're going to be less inclined to think, oh, you know, if you come in, you have a straightforward induction pathway where there's no delays, you'll be less likely to think, well, caesarean's an easier option. I mean, recovery time is so much better following a normal birth than it is following a caesarean. So it's our job to try and start promoting this again, really.
I can't believe the numbers.
I know.
It's incredible.
I was just having a look on
That's okay.
the UK, the average is 34%.
And we're 45 to 50 in Broomfield.
Yeah. Women given the choice electively, it's about 13%, and women are actually choosing.
Yeah, with national, that will take into a lot of your rural units as well, where their caesarean section rate is really low. So when you've got bigger general district hospitals like we have, it's always higher. But comparably, if you look at Liverpool, Manchester, you know, London, they're all higher.
But it is work being done nationally. Research.
Yeah, I mean, as I say, I think you've probably been on some of our meetings,
Yes.
Caroline, where we've spoken about Robson criteria, and that's the bit of work that only sort of came out in the last couple of years. So that's because it's where do we need to put, because there's no point doing lots of work if we're doing it in the wrong area. So it's trying to work out where is it coming from clinical decision making? Is it coming from women's choice? So we need to know what is the area that we need to put this work into. But yeah, it's somebody that came into midwifery many years ago. It's not what I thought would happen.
Councillor Spencer, you wanted to come
I was
out.
going to say, it's also quite complex, isn't it?
Yes.
Because, I mean, speaking from my own experience, I had 3 natural births and the 4th one was a caesarean.
Okay.
And the caesarean was, I was told there is no way you can deliver this baby, and in fact she ended up on a ventilator for 3 days. It was recorded as an elective caesarean. And I've always borne that in mind. So when you look at all these elective numbers, I'm not actually sure that they give a true picture. So it's just
I would say, obviously, I can't comment on that.
No, it's
It doesn't sound like it was an elective, to be perfectly honest. But I think actually you've raised a really valid point, is that is another thing. How many are electives? How many are emergencies? And that's, I think, going back to the question about the national, that's where the Robson criteria has come in. It is really multifaceted. You know, we're still built the same as humans. We can't have changed that much that we can't give birth anymore.
No,
so
exactly.
yeah.
But I think a lot more work needs to be done in this area. If I may pick up what Councillor Spenceley mentioned about her obstetric history. I had a caesarean and 3 natural deliveries. That is not encouraged now, is it? And I don't know why not. Sorry, I'm getting tactical.
I think, as I say, I think there's a lot. I think, you know, workforce is more junior, so maybe the experience isn't there. I think women's expectations are different. I think, you know, particularly, and I am generalising, but equally I am generalising from a point of knowledge because this is my job. Women want to know, when are they coming in? When are they having their baby? So that, you know, is a little bit more difficult as well. So
posh to put.
It would be amazing to be able to, every month we go down a little bit, we're really happy.
Sorry,
Somebody has a TikTok.
There's a little bit, I think.
It's at home with them. I wanted to ask one other question. Some time ago, Nikki came to us with a paper about reconfiguring Southend and putting some of that concentration into paediatrics. I wanted to know, has that happened? Has that landed? I know that we look at the whole of Essex. Southend do their job, which is to look at what was Southend, and they had a very different view on it than this committee. I wanted to know if that had now happened and what were the results, and are we seeing improvements in paediatric services? given the realignment that we were aiming for at the time?
So it hasn't happened yet, but what is progressing are those discussions around where services are provided, whether it's paediatrics, whether it's maternity, neonatal services, in terms of making sure we can deliver the best care with the right staff in the right location. So those conversations are happening in line with our 10-year strategy, which is the right, it's the right thing for us to do in terms of the delivery of services in the right place, but no decision has been made. But those other discussions are happening, not just about paediatrics or maternity, but about services across the 3 hospitals.
It's a shame actually that you were both parked in a cupboard downstairs on Jig Street, because if you had been here, we had either the finance or the chief executives of the ICBs, all of them for Essex. Some detail from them on finances and possibility, and it feels essential at some point that you're all brought together and have this conversation, one conversation in public, rather than hidden away at an ICB or something like that. I don't know, maybe it might be because I've been up since 4 o'clock this morning, but I've been setting homework today. And, the challenge, I think, grumpy, and I didn't even have one of the biscuits I bought you, but I've been setting homework, and we had a pre-meet discussion this morning that started at 9:30. We were talking about the trust, and we were talking about, if you like, a little bit of the history, given the fact that we've been as a HOSC panel together for 4 years, and we've seen that through literally its infancy as a newly formed combination trust. We're aware that you're now on your 3rd chief executive, and we mentioned many times in this room last year how many people appeared up there with the word interim preceding the title, but we know that a lot of work has been done. As a governor of the trust, and we have the lead governor here in the room, I feel and I see improvements all the time, but we have reports like this come through, and they don't help, but they're not useful. I mean, they're useful for you in terms of identifying and making improvements and giving you the impetus to say, okay, whether we've got the time, we have to now, and that's maybe largely the point. But I'd really like to arrange between this committee, and I'm not talking in a committee environment, I'm talking online or something. We were all, as governors, we were sent a quite complex structure of management, and who's the new this and the new that and the new the other. And we've seen Preeti has been here with her 10-year strategy, and we've fed into that, and she'll obviously come back when that's ready for that. So I'm not talking now, but I'm talking, can we arrange at some point in the future for this committee to look at that structure in regards to these reports, and kind of have a bit of a visual walkthrough on, okay, what does that look like? Because I noticed that there was groupings together of like Broomfield at this community hospital in Basel, and having to look at what that structure looks like and what people can expect from the service, because we're all elected here, whether it be to the hospital governing board, be to local constituencies. People ask us, and it's nice and it's helpful that we can support you by not just being here to provide challenge and support, but also in the community, because people ask us and we might know the answer. So we'd like
really happy to do that. Yeah.
We'd like to set something like that up.
Very happy.
We'll be in touch with the comms. Anybody, anywhere got anything else on the maternity items? I'm stunned into silence at how many people have gone, oh, no, I'm not talking about this.
If I may.
If you may, great boy.
Just a comment to Paula. I live in Billericay, and I can assure you I'd rather go to Broomfield than Queens. So I can understand.
I live in Billericay as well.
I can understand why ladies would rather go to Broomfield.
And it likes the role of the jag through stock.
I'm going to have to give Billericay a plug, because I was actually born there. You're okay.
I think
Right, well, that ended that item. So we have,
Presumably that's when we had some.
Okay.
Yes.
we're back in the room.
Down.
Thank you. very
Did
much.
you want to, the next item is actually the Mid and South Essex Foundation Trust monthly update. Is there anything you wanted to add to that?
No, I don't think there was anything in addition to what was in the paper at all.
All right, thank you. We're going to mute for a second because the floors are very noisy. You can get you back down to you.
Very much.
You're live on Channel 4, please do not swear. Apparently we can't mute. Thank you. They've gone and now we're muted. So all whispering has all been broadcast and now they're gone. Okay, so boys and girls, we're back and it's agenda item 6, which is the Mid and South Essex Foundation Trust monthly operational update. And we've had an addendum as well. If another item sent to you, I can't remember what it's about.
That was for the ICB.
Was it? It's a lot of papers and a lot of numbers in this one. So anybody got anything they want to add on this? Stu.
Thank you, Chairman. On 3.1 of the report, I noticed that there are increasing pressures in December on flu, and the fact that the flu vaccinations were capped in a number of areas of Essex in the time preceding that, and I wondered if those two were related. There's evidence of some of the providers of the inoculation service not having sufficient quantities of the vaccine, and therefore this is now reflected in increased infections.
Understand. Well, it's reflected not only increased infections, but only a surge. It has had a massive impact, and we've seen Nick Hume from Colchester and Ipswich hospitals in the press a lot about the increase in numbers through his ED department. We've seen the same with Matthew Hopkins and his teams across the board, certainly with Basildon Hospital, mentioned earlier on the number of over 500 people in an ED department built to hold 250 and process them across a 24 hours. So we'll take that as an action to write to perhaps public health colleagues as they sort of do along their own.
It would be interesting to understand the reasoning why they cut it back, given now that we've got evidence of the increases.
Yeah, so we'll speak to public health about that and maybe get some details also from the alliances and the ICBs on see if there is a direct correlation between that and the surge that we've seen in mid-December for flus that would normally take sort of end of January. Councillor Spencer.
So on 3.4, seems to be missing one thing here which interests me, unless I'm reading this correctly. I read it incorrectly. I've read it a couple of times. So it's on cancer performance. On the 62-day standard, the Trust saw a 4.8% improvement in November by starting to treat 46.1% of patients for their cancers. That's within the 62 days, presumably. But unlike the other figure, it doesn't give you what the national, target, but not the national performance on that one, although it does in the paragraph, the bit before. So it's, sort of missed off there. And I would like to, it'd be great to see, because that seems quite a low number.
We'll ask for the update on that.
Just being a bit pedantic here, 3.3, the percentages on ambulance handovers don't make any sense at all.
Talk me through.
Apparently we've got 30% within 15 minutes, 69% within 30 minutes, and 15% took over 60 minutes.
So the maths ain't math. Is that what you're saying?
Absolutely.
Okay. So we'll.
It's between 60. Yeah. It's between 30 and 60.
Okay. Anybody else? No. Right, we'll move on. So the next one is Princess Alexandria Hospital Trust, and that is the report. We've all had it. We've addressed it with the ICB that was here before. Councillor Harris, did you have something?
Yes, Chair, thank you very much. Very interesting report and quite telling. Obviously, we all visited the PAH over the past years and more recently last year. We've seen the state there and the way the jigsaw doesn't really fit what's needed there. So the new hospital is definitely demonstrated. But what concerns us, I think should concern us, is that we're in wave 2, which is 2030 to 35. 30 to 35 is some way off, even at the 30 end of the scale. But from indications and Stan, you were talking about earlier on, maybe 32. So we need to start thinking now about putting pressure on to make sure that happens, because you can't start planning, as we heard earlier on, until you've got some sort of demonstration of will. So I think we ought to, as a hospital, to the Secretary of State for Health, the local Labour MP for the area, and actually express our view that pressure ought to be put on to make sure that happens, because it would be in the interest of Harlow people for that.
More than happy to do that. I mean, I think what we do need to do maybe is pull in sort of an offline call with Arts and West Essex ICB and Michael Meredith as well, who's been here and obviously hosted us when we were there, to see what it is that they need from us. Happy to put the weight of HOSC behind it, but my concern with this, and I know this from the rollout of CDC's community diagnostic centres, is the escalating, ever-growing cost of these things. You know, Richard and I and the administration at Basildon at the time, we planned one for Pitsea. Loved it, loved the idea. We had the money. We were going to do this, we were going to do that. By the time we actually got round to doing it, it was like another 15, 20 million more than it should have been. And it's just one building. It's just one building. This is an entire huge hospital. And I think the thing for me would be, how early can we procure the land, make a decision on where is best, based no doubt around local plan and where housing is going to be, because there's no point junction 7A of the M11. Actually, nobody's got to live anywhere near there, or too many people are going to live there, or it's too industrial, or it's too this or too that or the other. And you want it somewhere that's not going to be landlocked like it currently is, where it's built to the, built to that route. So we need to have another conversation, and I think it would be worth having that conversation with elected local members as well, to find out how we as a committee can help secure its hospital that it desperately needs.
I think actually you probably just said, Chairman, what I was going to say, the pickup for me was the site, the lack of a site without issues. And I mean, on a much smaller scale, that was one of the problems that stopped a new St Peter's ever coming forward. And you can see on a much bigger scale, that's going to be the thing that's going to stop that coming forward unless it's resolved.
And, the biggest concern for me isn't, oh my God, it's going to be built within this parliament. It's not. It's going to be built more than halfway through the next. And you think about different sizes of different problems, different viewpoints. We've had far too many prime ministers in the last several years, and they all have a different idea about what the priority is. And Obviously, we're not elected nationally, we're elected locally. Although there's no representative of Harlow on this committee at the moment, this committee, it is one of the 5 hospitals that we look after, and we have been to it, and we know what problems are. So we'll look into it.
If you look at 4.7, you can hang the hat, I think, on the statement there where it says that if we don't do something early, it's the trust, the ability of the trust to maintain, and it says their words, continuity and safety of services. That ought to concern us.
Capital letters.
They're saying that, not us.
Yeah. And we've experienced it firsthand as well. A number of us have.
It's difficult. It's a difficult site, and you even think just something simple like staff parking. How much further? I'm going to be moving that to Broomfield very soon because it's just moving further and further and further off the site. But anyway, we'll try and have a catch up before we decide with some local members how we can assist Harlow in trying to see. So, what I don't want us doing is go and sticking a sticky beak into it, and Harlow have already got a campaign, or this person's got a campaign, or you've got councillors from one party, an MP from another party.
Exactly.
Politics is no place that it's a hospital, so how the hell do we support each other to deliver what we need for the residents? So that's where I am with it. Anyway, we're going to move on if members are happy to. So item 8 is the chairman's report. Nice blank document, nothing to have. We had for a long time that we were going to look at Basildon Hospital, and obviously with the pressures they're under at the moment, we've taken that off. We'll go back in spring when that's grown. However, perhaps to add to that, we are expecting an outcome of the St. Peter's reimagining consultation aware, and I want to visit the site before any publication of any outcome, because I don't want a paper coming back to here for a building we know nothing about. So we'll take names of those people who want to go on a day trip to Malden.
I think it would be particularly valuable because just this past week we've had real concern expressed by local over and apparently the staff there, the tissue viability unit. They found asbestos, they've got, various problems with the ceiling, they're frightened what's going to happen. So I just think it would be quite good to have visit there to see.
But it's not that I surprised the complexity of the problem, and you can talk about Harlow all you want, until you actually go and you see a 2-storey flat-roofed building that somebody decided, let's put a building on top of it. Only now the 2-storey roof leaks, but because of the building on top, you can't fix it. We need to go and have a look at that sort of problem. So that's where we are. So members happy with that?
Yes. Great.
We'll move on to agenda item 9, and we're never speaking to Councillor Harris again about JOST. So I will just very, very briefly mention the very few little things that I've been doing. Obviously, we did the Health Watch Essex winter wraparound, and when Sharon's back next month, if she's feeling better, she can share pictures and stories and figures. For me, Caroline Beasley-Murray volunteered us all for observing governors or governors listening groups. So I spent a day in Basildon Outpatients, which was actually incredibly interesting. Now, previously, we did this last year. We were in what's called the atrium, which is this new passage with shops either side, very bright and very beautiful. Awful. This year we were at the outpatients. A huge amount of different varied services on. There was diabetic screening, there was all sorts of different things. And it was a really, really interesting way of catching people. And we had a little preloaded iPad, and we would ask specific questions and they gave us the feedback. And actually, I thought as a governor, as chair of this, it was incredibly useful. And we could, of course, probe and ask different questions and more questions than I did. And there was one chap there who had been a long and very active patient, and he had recently had an amputation because he had spent many years in the diabetic aspect, but hadn't really taken care of that hadn't found a way of making that work, and he was now experiencing it from another thing. And lots of repeat patients, lots of older people. Parking was an issue. The guy with the amputation said, love everything, but you need to get a new chef. Other than that, everything was actually quite positive because these people were well experienced with Basil. And they knew what a bad hospital was, and this wasn't it anymore as far as they were concerned. So it's nice to actually go in there and talk to people. Don't hate it and don't. They're not that voice that you see, the one that's the loudest voice. They're not that. They're just patients that, and we'll be back next week like we've been every week before. So that was useful for that. And not for nothing, apart from anything else, I think actually that we're incredibly grateful to have somebody ask how they felt about the service, what they thought about the journey. Was it linked together properly? Did they have all of the information that they needed? I think the only problem that I encountered was the amputee chap, should have been a horse at the previous day, should have been a horse at that day. Something had gone wrong and they moved it to Basil. So his community transport hadn't clicked. So that didn't transfer over. Everybody at the hospital knew he was here, but the community transport had to be pushed to come and get him back. So with the exception of that, that was great. The only other item I have on that is that we held stakeholder events for candidates for the role of Chair of Audit at the South Essex Foundation Trust, having already, I think, done one round of them before that didn't find a suitable or successful candidate. And I would, Caroline might describe it or agree with this, I would describe the governor feedback as quite robust about the previous structure of how that was carried out. And significant changes were made, and it was the best way of doing these sort of recruitment panels I've ever seen. So it was well organised, good diary planning, 4 really, really strong candidates with really good qualities, 2 that were obvious choices, and 1 that stood out in a way that was just different and actually unanimous. And if you'd have been interviewing him separately, I think we'd have all arrived at the same, maybe the same result. So we have, I think next week we have another meeting to ratify that decision according to the Constitution. But that was that, and I think
of course the trust is now looking to recruit a new chair of the board.
So we announced a few weeks ago that Nigel Beverley will be stepping down in April. So we've got a meeting for that next Monday, an EGM or something extraordinary, where we're going to ratify the chair of the audit committee and also, I think, generally give the nod for the job description and what have you for the role of chair, some of the structure of what that looks like. So that is that for item 9. If nobody else has been anywhere or seen anything or done. So then we're on to item 10, which is our work programme. Yep. What to talk about 106?
No, I'm going to mention 106. As we know, we're going to be here a little longer. Down to longer. One of the things we often talk about here is how the NHS helps other groups like doctor surgeries, clinics that go out and what have you. I'm just wondering if we perhaps need to look at it from the other way around. How can we help those clinics, doctor surgeries, in going back to the NHS and saying, well, look, they're not getting this support?
I guess there would be an element of identifying what it is that we think that they're not getting.
Yes.
I'm not sure that they think that.
Well, I can only speak for my local surgery. They feel that they could offer a lot more services to the NHS, but not getting the support from the NHS to be able to provide that.
So, financials?
Not necessarily financial, but...
Because all of these services are commissioned. So
yes, yeah.
It's whether or not there's a clinical need in one particular area or another, and whether or not there's the capital funding to provide that. We've got we have a new diagnostic centre, and it's going to be a private hospital opening in Port Debenhams in Basel, and people are saying you're going to do NHS, and it's if they ask us to, if they commission us, so they will be able to do private ophthalmology, and they'll be able to do NHS as well, provided the NHS commission it, and that's so. Happy for you to have a look and see where you want.
Just thinking that perhaps we need to look from the opposite end of the. Sorry.
Have a look at the effectiveness, because obviously GPs have representation on the alliances, which have representation on health and wellbeing, the ICB. So it'll be interesting to see whether the representation representing GPs on any of those levels are saying the same thing that GPs. Anybody.
Following on from that, and I have raised this a couple of times before, which is in terms of mapping need, and particularly in terms of general practice need, and how we map the location of general practice geographically where the need is placed. We've got a number of doctor surgeries which have closed right across the county in the last few years, which have left areas uncovered or not covered by local GP surgeries. And the question that I raised with, I'm not sure who it was, now I'd have to go back in my notes, but is somebody looking at the need across the county geographically and mapping the new resources or changed resources or expanded resources in existing services, and finding out where those deprivation gaps were in terms of delivery of GP services and ambulatory services as well.
Sort of follows on, doesn't it?
So it follows on. So we did raise the question. I haven't seen a response to that.
Okay. Can we check that as an action? So I think my own view on that is that it all feels backwards, trying to plug a hole rather than actually aim for where we are. So we would know that if we build 20,000 houses, what that looks like in terms of a school, what's that look like in terms of the hospital? If you're adding 20,000, so Richard Moore's done a plan, here's 20,000 houses, they're going in that field, and the big built on Friday. When do you need the school? When do you need the hospital? When do you need the GP? When do you need the bus routes? When do you need this? We know what that top number looks like, because we know what we have a reasonable expectation, because we have government figures. We have all of these algorithms that will tell us how many people 20,000 houses is. So why is it that ultimately after 27,000 houses, what that looks like in terms of the infrastructure need, why is then that not divisible? If all of this is to get to a target of 2040 or 20 whatever it is, why is that then not divisible backwards to say, right, okay, so every one of these houses that you're going to take off your list needs to provide this for that, this for that, this for that, this for that. And if they're not viable, they're not viable. That sounds
It's not just that, it is the reverse of that. If you take my own division as an example, a lot of those houses were built in the 1930s, 40s, 50s, 60s, and have got surgeries that have closed down in the last 10 years. So I've lost 4 surgeries in that division, and the need was there. We actually had services, and those services were provided, and there's now no mechanism to put those services back.
In many cases, and I would say this, in many cases, as somebody that lives in the new town part of a new town, we were often vastly over-provisioned, which is why some of those surgeries have shut. So there were certain partnership groups in Basel and in London that had a surgery here and another one there. And they've got a capacity of this, but a need for that. And so some of them have actually just merged, and some of them have, some of them have been entirely the wrong places in rack houses. If you think the night surgery in Basildon was in a house that virtually fell apart, so I've got it on a demountable next to the sporting village in Gloucester Park, and actually it's a fantastic building, far more capability and productivity than the other place ever had. It's just different. So we've got the point of the question we're asking.
Well, just to add to that, although I've still got surgeries, I know you've lost yours completely, but there's been a number of surgeries in my division where it's been a one-man surgery.
Yeah.
That person is then looked to retire, the facility to a larger surgery, but that surgery has not been able to take on any more staff or anything to actually cope with those additional numbers. Yeah. So where they've amalgamated, they haven't expanded those.
The business model is wrong.
Yeah. I understand. Yeah. But it's exactly the same as opticians. When a private independent optician goes, do you know what? I'm 70, sod this, and sells his book. Then it goes down the road.
Yes.
And they might never see half of these people, ever. All the people on his records, they
Nobody buys it.
But if he does sell it, he sells it. Half those people don't exist. Half of those people have moved. They're in Australia or something. Yeah. It's just the same. It's the same idiotic model. And it is broken. And I think while you've got a national government that's shocking a stick of dynamite in the filing cabinet drawer and closing it quickly to shake it all up and see what's different, these are the things that maybe we should be having conversations about and challenging. This way isn't working. Could we try something else?
Yeah. I mean, that was my emphasis on the need model, because the geographic need will then drive where we're providing services.
I understand.
So we need more 106 money.
Of course they do.
Sorry, Chairman, I had to get it in.
Okay, 106. Are you all happy with the work program?
Yes.
Are you all happy for me to now close the meeting, given that we have no or exempt business? And the next meeting will be held on Thursday, the 6th of March at 10:30 in this very room. With that,